and good afternoon. I'm delighted to be able to present on behalf of our project team. This project would never have been completed without the funding we received from NEMICS, so I'd like to start by thanking NEMICS for the opportunity. I would also like to acknowledge the importance of the NEMICS Grants program in providing funding for clinicians like myself to help us to ensure we continue to provide high quality care and outcomes for people who've had a diagnosis of cancer. The background of this project was a concern within the clinical team working in the Austin Health Palliative Care Unit that the physiotherapists may not be involved with the right patients. Obviously, we wanted to ensure there was no service gap. But who are the right patients and how do you measure benefit? This project was designed as a scoping project to provide the foundational work to help answer these questions. But before we could answer the questions, we had to really understand who was admitted to the Austin Palliative Care Ward. Data is already being collected routinely as part of clinical practice, and we wanted to see if this data could be accessed and that it was robust enough to be able to be used to answer clinical questions, especially on trajectory. The two main databases we used were the Austin Health Clinical Data Warehouse and the Palliative Care Outcome Collaboration, or PCOC database. This is a national collaboration which uses validated standard assessments for palliative care settings. We specifically wanted to see if the raw Austin site-specific data could be accessed and used to gain information on function and clinical stability. We looked at the 800 admissions in the 12 months of 2022. This provided a rich data set for us to examine. The most striking ward demographic was the mortality rate, which was sitting at 81%. As yet, we haven't compared this with other palliative care wards, so we're not sure how unique this is. We also found that physiotherapists weren't reliant on referrals received from other members of the treating team. In total, physios were involved with about a quarter of the patients admitted, and over half of these were not referred by others, but identified by the physio team independently. The people the physiotherapists were involved with were a very different cohort from the whole, as shown on this graph. As you can see, there's a significant difference between the two curves, both in the slope and the gap between them. Now, if this was describing a medication, then everyone would be rushing to use that drug. However, I think we can all agree that physio intervention, no matter how good and magical it might be, does not have a direct impact upon mortality in this cohort. So what we're really seeing here is that the physiotherapists were extremely good at picking the cohort of people most likely to survive longer. The group seen by the physiotherapists' mortality rate was 59% as opposed to 86% in the other group. Next, yeah, thanks. From the PCOC data, we use the AKPS assessment. The AKPS is a measure of physical function, and as you can see, the physiotherapists were involved with people with higher scores. Clinically, this translates to people who are able to actively participate in treatment and are likely to have the physical reserves to tolerate it. You can also see that there was a greater percentage of people discharged from this group. Another part of the PCOC assessment rates clinical stability. As you can see from the colours, the areas coloured green, the physiotherapists were involved with people who remained in the stable phase significantly longer. An interesting difference between the groups was the cohort that was seen by the physiotherapists had significantly higher Charlson index scores and more comorbidities. The Charlson is used as a predictor of long-term survival, a higher score indicative of a worse outcome. This seems counterintuitive, but perhaps suggests that the physio assessment has a very different focus. Our key findings. Next slide, thanks. It's feasible to get access to the data already collected and stored at Austin Health, and that the data is robust enough to answer clinical questions. The physiotherapy assessment was able to identify a very different cohort of people within the whole in terms of survival and discharge. The best part of the project for us was when our Director of Palliative Care said she felt a huge relief that the people most able to participate and tolerate physiotherapy interventions and thus probably benefit were the ones that were being identified and seen. Unexpectedly, when we ran all the variables of diagnosis, Charlson score, age, etc. through our model, the strongest predictor of survival was whether a person received physio or not. We hypothesised that the physiotherapist's use of a validated frailty assessment, which includes an understanding of a person's function in the 2 weeks prior to the admission, is a significant factor in their ability to prognosticate. And to finish, I wanted to recognise the project team and our wonderful and wise steering committee. Everyone who's named you played a role in delivering this project. The project relied heavily on the expertise of Dr. Jennifer Jones to extract raw data and to build usable databases. And without this, we wouldn't have had any results to report. And I wanted to especially thank our 2 consumer representatives, John Clements and Catherine Kelly, who were major contributors to our steering committee. That was a lot to get through in 5 minutes. I hope everyone managed to understand what I was saying, and thank you all for listening.
Thanks so much, Andrea. Next, I'd like to introduce Olivia Power, who's Clinical Project Lead at Mercy Health.
Good evening, everyone. I'm presenting on behalf of Mercy Hospital for Women, who received a service improvement grant aimed at enhancing the supportive care screening rates among our cancer patients. We are deeply grateful to NEMICS for granting us the opportunity to undertake this essential project. Their support, along with the collaboration we received across various departments within the hospital, has been instrumental in our success to continue to provide high quality care and outcomes for people who have been diagnosed with cancer. Supportive care screening plays a pivotal role in identifying the unique needs of cancer patients, allowing healthcare providers to offer comprehensive and tailored care that addresses not just their medical condition, but also their emotional, psychological, and social needs. Unfortunately, our analysis revealed that the supportive care screening rates at Mercy Hospital were well below the expected targets, partially due to an introduction of scanned medical records taking away visual cues, COVID, and low staff training. This meant that a significant number of patients could have been missing out on vital support services that could help them navigate their treatment and improve their overall quality of life during such a challenging period. With this grant, our primary objective was to elevate the supportive care screening rates to an ambitious target of 80%. This aligns with the Department of Health's guidelines, which emphasises the importance of supportive care in enhancing patient outcomes. Achieving this goal would not only ensure that more of our patients are properly assessed and supported, but it would also foster greater satisfaction with the overall care experience at our hospital. By focusing on these improvements, we aim to create a more compassionate and responsive healthcare environment for those facing cancer. To address this challenge, we implemented a multifaceted approach by completing an in-depth review to what we were doing and identification of barriers to screening. We revised existing procedures to ensure supportive care screening became a standard part of patient care and made the process of supportive care screening more straightforward to staff. We created an alert flag within our patient management system, which allows healthcare providers to quickly identify which patients have not yet undergone supportive care screening, facilitating timely intervention. We updated our inpatient ward journey boards and handover sheets to include supportive care screening status. This ensures that all team members know each patient's screening status during care transitions. We initiated a supportive care screening champion role, and these champions are responsible for promoting screening within their teams, ensuring compliance and facilitating discussions about patient needs. We developed localized training materials to educate staff on the importance of supportive care screening and how to implement it effectively into their daily routines. Clear expectations were set for staff regarding the completion of supportive care screenings, fostering accountability and encouraging a culture of supportive care within our organisation. This cultural shift has enabled our team to be more responsive to our patients' diverse and evolving needs. The outcomes of our initiative have been truly remarkable. Over the span of less than 5 months, we successfully increased the supportive care screening rate for chemotherapy patients from just below 50% to an impressive 87%. This significant improvement highlights not only the effectiveness of our targeted strategies, such as enhancing training for staff, streamlined communication processes, and increased patient outreach, but also underscores the unwavering commitment of our dedicated team to prioritising comprehensive patient care. Their hard work and focus on addressing the needs of our patients have been instrumental in achieving these results, ultimately contributing to better overall patient outcomes. And yeah, so thanks everyone for listening.
Thanks, Olivia. Next, I would like to introduce Emily Minopoulos, who is the Leukemia Coordinator, Clinical Nurse Consultant at Eastern Health.
My name is Emily Minopoulos, and I am the Leukemia Clinical Nurse Consultant from Eastern Health. Sorry I couldn't join you in person at the NEMICS Annual Forum. I'm up in Queensland at our National Haematology Conference, so please enjoy these slides in my absence. My NEMICS Service Improvement Grant was the development of an outpatient Venetoclax model of care. So for those of you unfamiliar with haematology or who are unfamiliar with leukemia treatment, Venetoclax is an oral medication used to treat adults with newly diagnosed acute myeloid leukemia who are 75 years of age or older, or who have medical conditions that prevent them from using standard chemotherapy. Management of patients beginning treatment with Venetoclax has been largely inpatient-based. With advances in the understanding of leukemia and treatments, as well as improvements in supportive care, patients are increasingly being managed in the outpatient setting. So with this in mind, I decided to use the existing Eastern Health Leukemia database and perform a comprehensive data analysis with the aim of establishing a new pathway which would move the delivery of Venetoclax from the inpatient setting to the outpatient setting. This would also help to achieve a more patient-centered model of care. The key findings of my project were that patients that will benefit from the new model of care are evenly split between males and females. The average age of patient that will benefit from the new model of care is 74 years old. However, the age range varied from patients in their early 50s all the way up to those in their late 80s. The average length of stay for patients receiving Venetoclax ramp-up dosing as an inpatient was 11 days. Therefore, the outpatient Venetoclax model of care will move care of these patients to the outpatient setting, saving an average of 11 inpatient days stay per patient. And 82% of patients that received Venetoclax ramp-up dosing as an inpatient had at least one emergency department presentation post-discharge from hospital. A key element of this newly developed protocol moving forward is to further prevent avoidable ED presentations and continue to establish a process for facilitating direct inpatient access when necessary for patients receiving Venetoclax in the outpatient setting. Patient quality of life is a key driver of outpatient haematological care. Instead of being defined by their diagnosis, patients can simply factor it into their lives. After a diagnosis, being able to receive treatment in an outpatient setting can give patients some normalcy in their lives. It provides a sense of flexibility for patients. If the only benefit patients obtain is remaining out of hospital, that alone can literally be life-changing. Thank you.